management of giant cell tumor in different locations, and Professor Mohamed from Nasser Institute will speak about management of benign tumors. تفضل دكتور محمد بيه عبد الرحمن.
بسم الله الرحمن الرحيم. انا بشكر الدكتور محمد بيه وبشكر الاخوه الزملاء عادل ومحمد فاروق والدكتور محمود انديل على وجودي ما بينهم، وان شاء الله يعني هنحاول نسمرايز المين داتا اللي تهمنا في هاو تو ديل ويز ا كيس اوف جاينت سيل تيومر. طبعا هنبتدي الاول بانترودكشن كده بسيطه سريعه عن الجاينت سيل. طبعا الموست تشالنجينج تيومر بناين تيومر. ليه؟ لانها لها كاركتر من اول اللو بناين كاركتر اب تو انها ممكن تبقى سيميوليتنج الهاي جريد مالجنسي characterized by significant bone destruction ولوكال ريكارنس ريت عالي. بالسمبل كريتاج تقريبا بيبقى حوالي 50-55%، وفي 3% من الحالات بتعمل بناين ميتاسيس في اللنج. وده كاركتر لكل الابيفيزيال تيومر. لازم برضه معروفه للناس اللي داخله امتحانات ان الابيفيزيال تيومر سواء الكوندروبلاستوما او الجاينت سيل تيومر بالرغم ان هم الاثنين بناين تيومر بيعملوا لانج ميتاسيس وبتبقى بناين ان كاركتر. Most giant cell tumor بتبقى located within the epiphysis of long bones by time it grow and extend to the metaphysis and sometimes may be epiphyseal metaphyseal diaphyseal لو هي neglected لفترة طويلة. 50% of cases are located around the knee as a distal femur بنسبة تقريبا حوالي 37%، والبروكسيمال تيبيا بتوصل تقريبا حوالي 23-24%، فنسبة عالية جدا بتبقى around the knee. وطبعا الجاينت سيل بتكون حوالي 5% من الاول برايمري تيومر وحوالي 20% من البناين تيومر، والايدج انسنس بتاعها بيبقى الثيرد والفورث ديكيد، والموست كومن بتبقى ما بين سن 25 to 40 years. والفيميل للميل بريدومينانس بيبقى 3-1 تقريبا، وفيري رير انها تبقى ريبورتد بيفور سكيليتال ماتيوريتي، تقريبا النسبه بنسبه 2-5% انها تحصل قبل سن ال 19 years، لكن الموست كومن بتبقى افتر ذا ايج اوف 20. وفيري رير وخصوصا في الفيميلز انها بتحصل في سن قبل ال 15 سنه. يعني في سام ريبورتد كيسز تقريبا انا لو قلت ان انا عندي مثلا 1000 حاله جاينت سيل تيومر منهم حالتين فقط اللي موجودين بيفور الفول سكريتال ماتيوريتي. موست كومن زي ما قلنا بتبقى في الابيفيس اوف لونج بون واكستند انتو ذا ميتافيسيس، وبتبقى بريزنتد ببين. ده الموست كومن بريزنتنج سيمتومز، لان الجاينت سيل فيها كاركتر ات جرو باي اكسبانشن، وبالتالي بتزود الانترا اوسياس تنشن والانترا مودلر بريشر، فبالتالي هتعمل بين، وبعد شويه الكورتكس بتبقى سن لانها بتعمل اندوستريال ايروجن وبوشنج اوف ذا بروستيوم، فبالتالي هتبقى بريزنتد بسويلنج وديفورميتي في الاسوشيتد لارج ليجن، والمرحله الادفانسد هيبقى فيه سوفت تيشو اكستنشن. تلت الحالات تقريبا بتبقى بريزنتد بباثولوجيكال فراكشر فور ذا فيرست تايم ات تايم اوف دايجنوزس، وده برضو من الفيتشر بتاعها ان العيان ما عندوش اني كومبلين كومبليتلي اسيمتوماتيك بيلس، واول اوف سادن ماينور تروما بيحصل له باثولوجيكال فراكشر. وطبعا السيمتومز ارايز when the lesion becomes destroy the cortex and irritate the periosteum ونتيجه ويكرنج للبون، وده بيبقى البريدوميننت فيتشر بيفور اللي بنسميه الامبندنج باثولوجيكال فراكشر. طبعا عباره عن اكسبانسايل اوستيوليتيك ريديوليوسنت ليجن. الاهم فيتشر في الجاينت سيل تيومر ات از ا نون ماتريكس بروديوسنج تيومر، يعني بتعمل بيور اوستيوليسيس وزاويه سكليروزس. فيري رير انها تعمل سكليروتيك مارجن لانها بتاكل كل الاندوستيوم وبتبقى كونتيند وزين البروستيال ممبرين، عشان كده بتجرو باي اكسبانشن، وبتبتدي دايما ليوسنت اكسنتريك اللوكيشن، وبعد كده ما تبقى نيجلكتد لفتره تاخد الهول دايمتر اوف ذا كوندايلز بتاع الديستال فيمر او التيبيا. واهم فيتشر فيها انها بتوصل سب ارتيكولار، بيسموها جاست شورت اوف ذا جوينت، يعني سب كوندرال سب ارتيكولار، والريميننج بارت من السب كوندرال بوم احيانا بيبقى كومبليتلي ريزوربت مع الاوستيوكلاستيك اكتيفيتي اللي هي بتبقى الفيتشر الاساسيه فيها، وبالتالي بتبقى واقفه على الكارتليج، وهنشوف كام حاله وهاو تو بيلد الجوينت والكلام ده. Giant cell tumor can appear aggressive and characterized by extensive local destruction, cortical breakthrough, and soft tissue expansion and intra-articular extension in some cases, especially in joint with ligament crossing both sides of the joint, intra-articular, like the MB joint and the knee joint and the hip capsule through ligamentum teres. And in such cases, it is called multicentric giant cell, present in the acetabulum and the head of the femur, present in the distal femur and the proximal tibia, present in the base of the phalanges and the head of the metacarpal, due to extension and through ligamentum teres in the hip and ACL joint ligament in the knee joint. Sometimes located in flat bone like the pelvic bone and in the ribs and in the clavicle and in the talus and giant cell, but it is very rare in comparison to the around the knee. وبتبقى زي ما قلنا lack of dense peripheral sclerosis وبتبقى فيها multiple septi احيانا بتديها لو معاها secondary aneurysmal bone cyst so bubble appearance وتبقى uniform growth of the septa. طبعا كامبناتشي قسمها الى 3 جريد، latent جريد اللي هو جريد 1 وجريد 2 اللي هي الاكتف والجريد 3 اللي هي الاجريسيف. جريد 1 تبقى ويل ديفايند margin and intact cortex. جريد 2 بتبقى relatively defined, well defined but with radioactive rim without sclerosis and send out cortex and slightly expanded but without penetration of the periosteum. Grade 3, it is very aggressive and characterized by cortical destruction and sometimes periosteal breach, and has no correlation between the recurrence or the aggressiveness. And this is a diagram which is famous from Campanacci in the giant cell tumor of the distal radius. The first one is the latent. The cortex is intact without expansion, without ballooning and eccentric location. In grade 2, active, there is thinned cortex, but it is still well defined, not penetration. Grade 3, it is very aggressive with cortical breach and soft tissue extension. And this is a classic X-ray feature of 3 types of active, latent, and aggressive. The difference is well evident. Here, it is well contained. There is bone all around, eccentric. Here, it is thinned but not penetrated. Here, soft tissue expansion, there is no cortex at all. This is a very evident X-ray showing the different 3 types. طبعا sometimes we need to perform a CT scan, especially in around the knee and intrapelvic type to show cortical penetration for the floor of the acetabulum or the articular surface. And sometimes a normal X-ray without pathological fracture in the CT will be what we call subtle fracture, which is apparent only in the CT, not present in the X-ray. طبعا characterized by complete absence of bone. Intralesional mineralization also is absent and may be discovered pathological fracture delineation. And here, classic 3 example, here proximal tibia, well circumscribed, there is no cortex, it's very thin, but there is it is subperiosteal. Here the same in the femoral condyle, and here what is we call subtle fracture, although the lesion in the X-ray is showing no fracture. MRI is very important to delineate the extent of the neoplasm. The signal intensity is usually homogeneous and the region is well circumscribed. And the detection of the soft tissue changes, intra-articular extension and the marrow extension also, and the subchondral breakthrough and the penetration into the adjacent joint is really evident in the MRI. And here a different example. Here, one of the cases that occur in a female at the age of 16 years, before skeletal maturity, as we see, the epiphysis is still present, and by biopsy, it is a classic giant cell. Here, the lesion is present eccentric, reaching to the subarticular, but not penetrated the joint, and there is few millimeters still intact. And here, it is just short of the joint, and the edge of the cartilage, but also the joint is not penetrated. Here, there is breakthrough in the giant cell tumor of the distal tibia with expansion intra-articular in the knee joint, as we see. And this is a case of recurrence around the cementation at the wrist, showing the soft tissue extension, and here it is not separable from the major tendons. And here, giant cell tumor of the talus, showing the central eccentric location, and here it is posterior, but not destructive to the posterior cortex of the talus. It is still contained, as we see in the sagittal and the coronal views. Grossly, the giant cell tumor is characterized by shackled brown, soft, spongy, and friable. That is we called maroon appearance. It is like a marsurized liver. يعني دايما بنسميها maroon type اللي بيسموها عامله زي الكبده المهروسه. Yellowish to orange discoloration ده بيبقى فيها الاماونت اوف هيموسيدين جرانيولز بتبقى اقل، وبيبقى فيها كوليسترول كريستال، وده عشان كده بنشوفها باللون اللي احنا بنشوفه اصفر دايما. طبعا بيبقى فيها sometimes cystic cavity وبلاد فيلد cavities اللي هي بتبقى acquired secondary aneurysmal cyst from hemorrhage or repeated trauma on the surface of the tumor. And here the different gross appearance, here with pathological fracture, and here the classic maroon appearance and fibrous and zomatous type, and occupying the whole epiphysiometaphysal area reaching to the edge of the cartilage in the distal femur, and here in the distal radius with pathological fracture, and here with intra-articular fracture as well, and here in the head of metacarpal. Histologically, it is a multinucleated giant cell looking like the stromal cells, mononuclear cells, spindle in shape, with the same arranged nuclei, characterized by multinuclear appearance, maybe from few up to 100 of thousands of multinucleated appearance as we see in this case. طبعا there is various treatment option for the giant cell tumor, and it is a debatable presentation usually because there is no specific line of treatment in the before the last 10 years. It may be curettage, simple curettage, curettage bone graft, curettage insertion of bone cement, cryotherapy, curettage of the cavity chemical adjuvant arising from zinc chloride, alcohol, hydrogen peroxide prior to the insertion of the cement or bone graft. In aggressive type primary resection, radiotherapy in the spine and the pelvis, embolization of the feeding vessel to minimize the vascularity. As we see, 8 different techniques. But in the recent few years, if you want to get a better clearance to minimize the recurrence rate up to 1 or 2%, you have to follow the guidelines recently, and we'll discuss in details. Treatment of giant cell is via surgery. There is no conservative treatment. It is only by extended curettage. And the treatment of choice is complete steps of curettage, starting from simple curettage, mechanical pairing, and adjuvant measure. Simple curettage will yield a recurrence rate very high. It may reach up to 55%. And in the distal radius, because of its complex configuration and different corners, it may reach up to 88% or more. So curettage must be followed by many steps to eradicate the tumor. The technique of high-speed pair of the cavity after simple intraregional curettage, we must obtain a large cortical window necessary to expose the entire tumor and the tumor cavity, allowing thorough curettage and bearing of the cavity. These have found to reduce the recurrence rate to 12 to 25% by mechanical curettage. Minimize the recurrence from 50% to 25%. يعني تقريبا بننزله قريب النص. And by the addition of the other technique, it will descend to 1 to 2%. The high-speed pair not only adds a thermal component to eradication of the tumor, but allows more thorough removal of the tumor. It must be followed by chemical or physical adjuvant and backing of the region with BMA or a bone graft. Liquid nitrogen, it must be used nowadays in all the cases. Most of the cases of giant cell tumor, if liquid nitrogen is used, it will minimize the recurrence rate from 50% to 1 or 2% only. Beside the other 2 steps, mechanical use of the pair as we mentioned. The chemical reagent is the liquid nitrogen. It is acted by many techniques, resulting in intracellular death of the cells with disintegration by the freeze and thaw techniques. And the process must be repeated at least twice to obtain a cellular death of about 2 centimeters. The cavitary defect is followed by reconstruction by cement or bone graft, as we mentioned. The cavitary defect is then constructed with cement and augmented with embedded styrene pins or thick wire or long screws. This is an added option in the last few years because cement, if recurrence occur, it will be loose and result in spread of the tumor with its loosening. So it is better to embed screws, long screws, as we will see, or Steinman bends or very thick wires to prevent the migration or loosening of the cement. And here cases done in the last decade by one of our colleagues, case of eccentric giant cell tumor. If the steps followed, it will be not result in recurrence. This patient was operated 4 times with 4 times recurrence time by simple curettage and the bone graft, and another time by simple curettage and cement, and it presented by this last X-ray on the top on the right with extensive recurrence around the cement, as we see in the MRI experimentation, and on the 4 times there is no adequate curettage, no adjuvant measure, and ended by wide resection like a malignant tumor and reconstruction by endoprothesis. And also the most important is to build up the subchondral bone, because putting a cement in the articular cartilage result in early degenerative arthritis within 3 to 5 years. So to prevent this, especially giant cell tumor occur at a young age, about 30, we must build at least 1 centimeter from the subchondral bone by impacted cancellous graft, as we see in the diagram and in the cases. And here is the case done by just cementation, presented by advanced arthritis within 3 years, with collapse and the marked narrowing of the joint plus recurrence of the tumor. And this is after 5 years, the patient was presented with severe varus and advanced osteoarthritis of the knee, as we see, ended by proximal tibial resection and the endoprosthetic replacement. To avoid this complication, we must build up the subchondral bone, as we will see. And here, the last modification in the management, just simple curettage and cementation, as we see, result in this picture: loosening and recurrence, and the cement becomes mobile in all directions. And here, see the cement on the MRI and this extensive recurrence around. So if the steps followed accurately, the recurrence rate will be minimized, and the augmentation of the cement by screws or intramedullary fixation nails will minimize this complication, and ended by loosening of the cement and the contamination of the large part of the quadriceps, also ended by wide resection and endoprosthetic replacement. So the ideal standard operative steps must be curettage by manual curette, evacuate the large part of the tumor, and followed by high-speed bear, followed by cryotherapy, and finally cementation with impaction subchondral iliac crest bone graft, with or without internal fixation according to the size of the tumor. When the tumor is less than 1 centimeter from the articular surface, the instance of degenerative changes in the articular cartilage after the use of cement alone is more than 2.5 times greater than when the tumor is more than 1 centimeter. So interposition of at least 1 or 2 centimeters of bone graft between the cartilage and the cement may reduce heat damage and delay the arthritic changes, and leads to successful graft integration later on. So the steps must be as follows. First step must be a large window. The window, there is no corner or undermined area like this on the right side. This is incorrect. You must do full drawing. Remove all the coverage of the lesion. No corners, no undermined angles. It will be harboring residual, so recurrence rate occur from this. The second step, the use of the simple curettage by the manual curette, followed by the mechanical by the bear, as we mentioned. And the third step, after the use of liquid nitrogen, is to build up the subchondral bone. If the cement is put like this, it will result in early arthritis. Must be interposed part of graft like this to minimize the heat injury of the cement on the cartilage and prevent the collapse or varus of the joint. And here an example. This is a huge eccentric lateral condyle of the distal femur giant cell tumor after biopsy and after full radiological evaluation by X-rays, CT, and MRI. As we see, the lesion is just short of the joint, but not penetrated. And this is during the biopsy, the lesion become more aggressive, and extended to the medial condyle. So, and this is the MRI showing the whole condyle from the coronal cuts, and but the cartilage and the edge of the joint is not penetrated. So the techniques through lateral approach, full extensile window, debulking of the tumor by curettes, followed by complete evacuation of the subchondral bone. Here the interior of the cartilage of the knee joint, and here after use of the bear with complete evacuation, it is become clean whitish. This is the interior of the cartilage, subarticular part of the joint. So we have to use liquid nitrogen after protection of the soft tissue by gel foam for 2 cycles, and after evaporation, we build up by impacted cancellous bone, and there is perforation in the posterolateral stratofibral graft also augmented with the cement and the multiple thick wires. And this is the post reconstruct immediate post-operative X-ray showing the cancellous graft, and this is the fibral graft for the posterolateral part, and this is the cementation and embedded wires. This is after 3 months, the graft starts to incorporate. After 6 months, remodeling of the graft. After 2 years, complete no recurrence, full integration, and the cortical thickening. And this is an MRI done 2 years showing full formed at least 2 centimeters of subchondral bone with no collapse of the joint. And this is the range of the motion of the patient. There is no limitation, normal function in all directions. And this is another case of extensive giant cell tumor in the distal femur. A few millimeters is still present from the subchondral bone in the MRI. It reaching into the intercondylar area, but the joint is not penetrated. It's the same principle: curettage, evacuation, bear, liquid nitrogen, and impacted subchondral graft and embedded wires, as we see, and followed by cementation. This patient immediate post-operative X-ray, and this 2 years there is cortical reformation, and this is 12 years follow-up. This patient presented since 2 months after trauma. It was disappeared for 10 years, and they come by this nice X-ray. There is no recurrence. There is cortical thickening from the loads, and the well-formed endosteum layer around the cementation, and the embedded wire gives durability for the reconstruct, as we mentioned. This is another case of eccentric recurrent giant cell tumor in the distal femur. This is a Yemeni patient operated in Yemen, and come by this recurrence for me, extensive recurrence. And this is during the surgery, the tumor is reaching to the edge of the joint. As we see, this is the intercondylar area, and this is the tumor extending into the subarticular area in the view. After evacuation of the tumor by large curette, hydrogen peroxide, and this is still remnant tumor tissue. So you have to use the bear followed by the cryotherapy, and this is the impacted subchondral graft to build up and embedded screw in multiple directions because the tumor is very huge. And this is after repair of the lateral ligament with closure of the soft tissue. And this is the immediate post-operative with the reconstruct by the embedded screw. And this is the impacted subchondral graft. This is after 1 year. Very nice integration and incorporation in the graft, no recurrence. And this is after 5 years. This X-ray was last week. The patient is in contact with me through WhatsApp, and he sent me this video. Oh, this is a Yemeni patient, and his function is excellent. After 5 years, although the distal femur was completely destroyed, and this his working is a manual worker, and he makes this video and sent for me last week with normal squatting. There is no limitation, although the patient become obese, and it is an excellent end result. And in the last case, presentation around the distal femur, which is a very aggressive form presented with pathological fracture like this, and after a good radiological evaluation, there is an extensive extension in all directions, and after the biopsy, it was a benign aggressive giant cell tumor. طبعا here there is no rule for curettage. because there is no contained cavity, soft tissue extension, contamination of muscles. So the best option in such aggressive case is to do a wide resection like malignant tumor with endoprosthetic tumor replacement. And here the MRI shows the extension in all directions. And this is the CT showing the same. Here the tumor is very huge. After planning of the wide resection, like any malignant tumor, with isolation of the neurovascular bundle and intra-articular resection, the defect was 26 centimeters, as you see in the rulers. And tumor proceeds with applied with distal femoral replacement. And this is the immediate post-operative X-ray, 3 years and 9 years. There is no recurrence, stable function, and proceeds also is stable without loosening. In the next location is the proximal femur. Sometimes we see many cases of giant cell tumor in the proximal femur, either in the head and the neck or in the apophysis, or what we call the greater trochanter. It is sometimes presented by pathological fracture, or like this case, during preparation and radiological evaluation, the tumor reaching to the subchondral bone, the patient suddenly developed pathological fracture after the biopsy. So قضي الامر في الحالات اللي زي كده ما ينفعش خلاص الفيكسيشن، لان الهيد والنيك ريزوربد، فلازم بنعمل بقى بروكسيمال فيمورال ريبليسمنت لغايه الايه الليسر تروكانتر تقريبا اكستنشن بتاع التيومر، وبنشيلنا تقريبا حوالي 6 سنتيمتر، وبنعمل برضو بروكسيمال فيمورال ريبليسمنت على كابت في كاب. والعيان ده انا عامله تقريبا بقاله اكتر برضو من 10 سنين، والحمد لله ماشي كويس. والحاله دي انا عارضها على التشانل بالفولو اب بتاعها بالفانكشن لغايه برضو من شهر تقريبا. برضه بيجي لنا حالات جاينت سيل تيومر في الجريتر تروكانتر ابوفيسيس like this case male patient 26 years presented by الاوستيوليتيك ليجن وفي التروكانتر. وافتر برضه كل الحالات لازم من الميديكو ليجال ومن الساينتفك بيربس لازم نعمل جايد بايوبسي اتليست اور اوبن بايوبسي. برضه دوكيومنت انها بناين جاينت سيل تيومر ذا سيم برنسبل lateral approach extended curettage cortical window and after the cryotherapy, we apply fixation because the neck is only the remaining part is the calcar area. After the extended curettage, DHS is applied and the filling of the cavity by cementation. And this is the immediate post-operative X-ray after the surgery. And this is follow up after 4 years. There is corticalization and thickening of the cortex of the trochanter around the cement, and there is no recurrence, and the function of this patient is excellent, and load sharing result in a cortical thickening of the medial cortex as we see after 4 years. And this patient is playing football without any problem. As regards cases of the proximal tibia, here a case of huge extending both condyles, and there is extensive soft tissue breach in the medial cortex. And here's a CT scan showing the lesion, MRI, but the joint is still not penetrated. It's just a shell of cartilage. Also, the same principle after a large window with drooping, curettage, evacuation, and repair. And here the subchondral bone of the proximal tibia, there is perforation at a certain point intra-articular. Liquid nitrogen, if escape intra-articular, it results in damage to the cartilage. So you have to seal the perforation by gel foam to prevent the escape of the liquid nitrogen intra-articular. And after that, a liquid nitrogen, here the empty cavity, it becomes clean, a full thickness, because the whole impacted graft, it will be, we have to take from both sides. In such a case, we just only take a full thickness tricortical graft and bisected, and the subcancellous area impacted subarticular to help in healing, and the other one is reversed like this. The cancellous surface is impacted subarticular to help in healing and fix it temporarily by wire. And after that, we do the cementation, and this is the impacted graft, and his follow-up after 3 months, 6 months, and after 1 year, full healing, and the joint is restored without recurrence of the lesion, and the cementation is in position. There is no problems. And this is the function of the patient. Excellent function without limitation of range of motion, full active flexion and extension. here another case of aggressive giant cell tumor in the proximal tibia, reaching to the subarticular area and with breach and soft tissue posterolateral extension. Also evacuation, and here there is no lateral buttress or posterior buttress. So the use of liquid nitrogen will be harmful for the soft tissue and may injure the, this area is the soleal arch just beyond us. So we don't use liquid nitrogen, we use the phenol. And it is a local adjuvant, gives penetration power 2 to 3 millimeter with cellular disc. And also recurrence rate of giant cell is diminished to 7 to 8% after the use of phenol. But after complete use of a curettage, repair, and the third step is the use of the phenol as an adjuvant, followed by impacted subchondral graft to build up the subchondral bone and multiple screws, because the defect is huge, and lastly cementation. And this is the immediate post-operative X-ray showing the subchondral support. Embedded screws must be long, at least 2 to 3 centimeters beyond the limit of the cement. And this is a follow-up after 2 years. And this is the CT. There is no recurrence. There is no collapse of the joint. And also the subchondral bone has been nicely integrated without collapse of the joint. And this is the function of the patient.
يلا مش اثني وافرد اثني الاخر اثني الاخر خالص كده بقى الاخر اوضح الخط المستقيم اثني للاخر اثني كمان.
And in the last case, which is very aggressive type with marked expansion and second aneurysmal changes, occupying تقريبا اكثر من نص التibia. Very extensive neglected case in a female about 60 years, presented late by this huge extension, and after biopsy it was proved to be an aggressive benign giant cell. So in such a case there is no rule for curettage. It must be salvage, wide resection like malignant tumor, and reconstruction by tumor procedure as we see. The next location is giant cell tumor of the distal tibia, also sometimes presented by such a huge expansion, eccentric lesion, posterior and lateral. And this is in the MRI with soft tissue extension, but still contained in the supraosteum, with just here in the area of the tibial plafond, but there is no actual penetration of the joint. So an extended curettage through an anterior window with evacuation, and that's followed by the complete steps. There is no posterolateral bone, just the medial malleolus and the medial cortex. There is no posterior or lateral wall of the tibia. And this is the interior of the cartilage of the tibial plafond. So we have to use in such a case, after the full steps of curettage, cryotherapy to minimize the recurrence, and impacted cancellous and defibular graft to build up the tibial plafond, and here posterior and lateral graft. And this is a patient after 6 months, and after 1 year and 3 years follow-up, there is no recurrence, the full integration of the graft and excellent function of the patient. As we see here, full integration of the fibular graft and the subchondral bone, healed cancellous impacted iliac crest graft, and here's the anterior and the lateral fibular graft nicely integrated with remote link. And this is the function as we've seen, excellent without limitation. Sometimes the cases with recurrent giant cell presented for us, such like case with infection added, patient evaporated by cementation, and there's aggressive recurrence extending to about 5 to 6 centimeters above the limit of the cement, and contamination all around the lesion, and the ugly skin with sinuses discharging pus. So in such a case, we have to include the biopsy scar or the previous surgery, like malignant tumor as a biopsy scar, must be resected, and a wide intra-articular resection, and a non-vascularized stratifibular graft with ankle fusion done. And here's a resected specimen showing the pus and the area of skin, and a free mobilization of the skin done, and it nicely closed without the need for skin graft, and an application of Elizarov to stabilize the graft, and this after 9 months, good nice healing of the osteotomy site with the double fibular graft and the fusion site, and this after removal of the roof, and this 4 years after removal of the roof with amalgamation of the tibia. Both of them become tibialized and the complete fusion proximal and distal. The next location is the giant cell tumor of the proximal fibula, usually presented very huge like this with expansion and secondary aneurysmal changes. So we have to resect the fibula. Giant cell tumor of the fibula, there is no rule for curettage. Also in the distal ulna, there is no rule for curettage. Recurrence rate is very high. Wide resection by safety margin at least 1 to 2 centimeter and must be included intra-articular after a separation from the superior tibial joint. And in such approach, we need to isolate and retract the common peroneal nerve and an osteotomy done distal with extraction of the lesion. And this is the nerve intact after the resection. And this is the classic maroon type of giant cell tumor. And here the resected part. Without reconstruction, usually we don't need a reconstruction in the fibula, as we mentioned in the lecture of the limb salvage. The next location is giant cell tumor of the proximal humerus. In such aggressive cases with soft tissue break and extension on the head, very extensive, and this patient was too young, it is about 28 years, presented with massive destruction of nearly 1/3 of the proximal humerus. And here after making the MRI showing secondary aneurysmal and the breach, as we see medially inside the axilla. And here the soft tissue extension just before operation. And here the extension. In such aggressive case, we have to do a guided biopsy to document it is not a malignant lesion, it is a pure giant cell tumor. Also, an extensile anterior approach done with evacuation of the tumor. It is a giant cell with secondary aneurysmal, as we mentioned, after complete curettage and application of nitrogen. And this is a very large fibular graft taken to reconstruct the major defect. One impacted inside the medulla, breastfeed, and the subchondral in the head, and another 2 grafts to fill the head and around the fibular middle graft. And this is the post-operative X-ray with the reconstruct. And here after 2 months, after 4 months, nearly healing and incorporation of the graft. And this is after 6 months, starting remodeling and complete integration of the graft. And after 1 year, nice healing without recurrence. And the head is not collapsed with excellent function of the patient, as we see. Full abduction, elevation, circumduction, all the function without any limitation. Also, another case presented for us with recurrent giant cell tumor after an operation. انا العيان ده يعني الجراح اللي عمله للاسف فتح له جرح بتاع 2 سم وراح جاي حاطط له حته ايه يعني ايزوبون كده جوه الكافيتي وما عملش اي كريتاج. فالعيان ده بريزنتد بالايه الريكارنس تقريبا قبل ما يفك الغرز. زي ما احنا شايفين الري ايفالويشن التيومر become extensive and a ballooning and expansion around the isobone synthetic graft, and this is the incision, very small incision for giant cell tumor. Must be extensile, large window, complete evacuation of the tumor, simple curate, bare, liquid nitrogen, and after liquid nitrogen, we put a different technique by embedded screws into the cement, 2 large full thickness, fully threaded cancellous screws. And after that cementation of the cavity, this patient operated since 4 years. There is no recurrence and full integration of the cement, and there is no major loosening, and the function is excellent. Also, the cases of giant cell tumor of the distal radius, there is no rule for curettage, bone graft, or cementation. Recurrence rate, as we mentioned earlier, is 88%, which is a very high rate of recurrence because there is multiple corners, styloid process, there is facets, there is radioulnar facet. So if you wanted to do a perfect curettage, you have to make a complete drooping of the radius. And if you make this, the radius will be fragmented. So it is better to do a wide resection and reconstruction by fibular graft, either intercalary fibular graft if you will perform an arthrodesis of the wrist, or if you want to perform an excisional arthroplasty by ligamentous reconstruction, you have to use the proximal fibular ipsilateral graft, as we'll see. And this is a case done by cementation and presented by us by recurrence in the stylo process, as we see, and in the ulnar process, in the just area adherent to the triangular fibrocartilage. Because curettage will not reach this area because it is very thin and there is nothing that can complete eradicate the tumor in such area. So, as we mentioned, recommendation is to do a wide resection of the distal radius and replacement. And this is also a case, third case presented by recurrence of and resorption of the graft. And after that, we do a full evaluation, extension of the lesion, and after retraction of the extensor tendon and an osteotomycete done, and the complete excision by safety margin, and must keep part of the ligament, capsular ligament from the styloid and the capsular ligament of the scaphoid if you want to do an arthroplasty. And after getting a graft from the ipsilateral proximal fibula with the styloid process with part of the biceps tendon and the lateral collateral ligament of the knee. And it must be matching to the size of the graft, as we see in the different photos. And after fixation at the osteotomycete with the distal radius, we reduce and we try to both the scaphoid and lunate over the facet of the superior tibiofibular ligament, joint. And after that, we make a complete reconstruction of the capsule and the part of the biceps and the lateral ligament in the capsule of the wrist joint and the scapholunate ligament in order to make an arthroplasty, not arthrodesis, as we mentioned. And temporarily we fix by K-wire in the distal radioulnar joint like this. But eventually, most of the cases will end by slight collapse and complete subluxation after 3 to 5 years, because the perfect matching between the lunate and the scaphoid is not the size of the superior tibiofibular cartilage area. And this after 1 year, slight subluxation start to occur, and after healing of the graft, marked subluxation. But the patient, if not manual worker and is satisfied by this with hand grip is weak but is sufficient for daily activities, there is no need for arthrodesis. But if the patient is manual worker or needs a strong grip from the start, we must perform an arthrodesis of the wrist. And in such a case, there is no need to take the proximal fibular graft. It may be intercalary, as we see in such a case. Also, this case presented by recurrence, as we mentioned, there is no rule for curettage in distal radius, must be resected. And I operate a very great amount of cases presented by recurrence after curettage was graft, curettage with cementation. The best option is to do resection without curettage, as we mentioned. And here, after full re-evaluation by CT and MRI, soft tissue extension of the tumor and the contamination posteromedial, we have to resect with safety margin, as we see, and we resect the distal radius completely after retraction of the major tendons, and we take an intercalary graft from the middle part of the fibula. There is no need to dissect and isolate the peroneal nerve and put the graft in between the carpal bone after dealing with the cartilage and the remaining part of the osteotomycete of the radius, and the application of a contoured blade with the functional position, slight dorsiflexion and radial deviation, and application of contoured blade with fixation with screw, either small, and such a case a recon blade can be used. And this is the immediate post-operative, and this is a follow-up after 3 years with complete integration and revascularization of the fibular graft and diffusion of the wrist and the healing of the osteotomycete without recurrence. In giant cell tumor of the distal ulna, There is also no rule for curettage. Recurrence rate is very high. It is better to perform a resection without reconstruction. Usually, there is no need for reconstruction of the ulnar giant cell tumor after resection. We just resuture the ulnar collateral ligament in the periostem of the radius and in the triangular fibrocartilage, and the function of the patient will be excellent, as we see. This is the exposure of the distal ulnar, resection and complete dissection from the ulnar collateral ligament, and here after the resection of the distal ulnar, and this is the tendons, and here reattachment of the ulnar collateral ligament, and this is the bisected specimen classic giant cell tumor, and here the immediate post-operative, and after 3 years follow-up, there is tapering of the osteotomy site, but the function is excellent, and this is the video showing the function of the patient. There is no limitation. This patient is a doctor, and it has an excellent function without limitation in all directions.
افتحهم بقى من فوق، ممكن بقى تحط الاثنين جنب بعض. لا الاثنين جنب بعض كده، ايوه. انضم بقى الاثنين لتحت.
The last case is the malignant giant cell tumor. Usually we confronted with such a presentation with huge extensive destruction. There is no subchondral bone area, just huge soft tissue occupying the distal femur with marked destruction. Here's the patella, and another case with posterolateral penetration, posterior penetration, huge soft tissue extension, and after biopsy, it was documented a malignant spindle cell in giant cell lesions, which we called primary de novo malignant giant cell tumor. In such cases, it is a malignant tumor. There is no role for curettage, and after full evaluation by CT, MRI, show the extension of the lesion, subarticulars, but no penetration of the joint, so a wide resection after the biopsy done with documentation of a giant cell tumor, but with hemorrhage, necrosis, and liquefaction, which indicate malignancy. And after reconstruction by tumor proceeds, this is immediate post-operative, 6-year follow-up, and this is 10 years without collapse or shortening has been happened. It is nearly the same length, a few millimeters shortening occurred due to collapse, but it is accepted. A few millimeters has no rule after 10 years with stable joint with no recurrence. Thank you.
Thank you so much, sir, for this very interesting talk. شكرا جزيلا أستاذنا الفاضل أستاذ دكتور محمد عبد الرحمن for this talk, collecting a wide variety of cases. Thank you so much, sir. دكتور محمود، دكتور عادل, moderators معانا. We are waiting for any questions to our eminent professor.
هو في one question for you, دكتور محمد, from دكتور زايد. Can cryotherapy damage the joint cartilage?
Yes, I have 2 cases in children with aneurysmal bone cyst in the proximal femur with a damage to the physial plate of the head of the femur with burst-like action. But healed conservatively. The patient was 4 years age, and after 3 weeks, started remodeling of the head, and at 6 months, it returned to normal. And also, if leakage of the liquid nitrogen intra-articular, especially around the knee, can damage the cartilage. So we must inspect the joint from the interior. If there is any perforation, and I present a case of proximal tibia, you must put a gel foam from the interior to prevent the leakage of the liquid nitrogen intra-articular.
طيب في سؤال تاني كمان لحضرتك من الدكتور محمود فتح الله، بيسأل ليه هو احنا بنحط وايرز وسكروز لما بنستخدم السيمنت يعني؟
احنا قلنا الكلام ده في اول المحاضره، ان الاسمنت لما بتحطه وبيبقى مش فيتنج الكافيتي كويس بيحصل له لوزننج بعد شويه، زي حشو السنان. انت لو حشو السنان بعد فتره بيفرول، بيحصل نفس المشكله. فالوجد بالماركوف وكذا واحد، وفي بيبر انا الحمد لله انا ناشرها من 2009 على الامبيدد سكرو دي. الفكره فيه بيعمل اوجمنتيشن، كانك بتعمل عمود خرسانه يمنع اللوزننج للاسمنت، يديله ديورابيلتي. الاسمنت ده ممكن يعيش فور ايفر، ما يحتاجش ريفيجن ليتر اون. بس زائد ان لو في ريكارنس ما يخليش الاسمنت ده هيبقى بيلق يبقى الاسمنت ماسكه في المضله، ما يعملش مور سبريد وكونتامينيشن للسراوندنج سوفت تيشو والماسلز.
طيب في سؤال كمان من الدكتور احمد الامام. How can you judge healthy bone from pathological bone intraoperative؟
باي انسبكشن بس. يعني الكلام الساينتفك انك مهما تعمل كريتاج في ريزيدوال مايكروسكوبيك سيلز. عشان كده الجاينت سيل ريكارنس ريت فيها عالي، قلنا بيوصل 50% في الحاجات العاديه، وبيوصل زي ما قلنا 88 90% في الديستال ريديوس والالنا، الحاجات اللي بيسموها السمول سلندر بون. عشان كده لازم تستخدم البير بيدي لك الاول، بنستخدم الهيدروجين بروكسايد بيدي لك نص مللي، بعد كده بنستخدم البير بيدي لك من 1 ل 2 مللي، لو هتستخدم الفينول بيدي ل 2 ل 3 مللي سيلولار ديس، يعني بيحولك الكريتاج لمارجنال كريتاج. زائد لو استخدمت النيتروجين بيعمل اوستيونكروزس وسيلولار ديس اب تو 1 سنتيمتر، فبالتالي بيمنع الريكارنس من نزول 1 ل 2%. فانت كل دي يعني اديشن عشان تو امبروف الايه الريزلت وتمينيمايز الريكارنس.
في سؤال كمان لحضرتك من الدكتور وائل ابو زيد. When using an intracalary fibular graft in the distal tibia or proximal humerus, do we use the cement or not؟
لا يعني في حالات الجاينت سيل ولا بيتكلم عموما؟
في الجاينت سيل يعني
انا عامل حالات كتيره في البري استابلر اريا، ما بتلاقيش الميديال بيلر اللي هو ماسك من الدوم بتاع الاستابلم لغايه الساكرو إلياك جوينت، والدنيا بتبقى احيانا كومبليتلي ريزوربد، بحط استرات فيبيلر من الامباكتد من الدوم بتاع الاستابلم للساكرو إلياك جوينت. الغرض منها بتمنتين البلفيك كونتينيوتي، وفي نفس وبعد كده بكمل عليها باسمنت. بس اهم حاجه لما تيجي تحط الفيبيلا ما تحطش اسمنت على الجنكشن ما بينها وما بين البون اللي هو السبكوندرال بون بتاع الاستابلم او الساكرو إلياك، لان ده هيمنع انها تنتجريت وتهيل. يعني دايما تاخد بالك من الحته دي، ما يبقى يعني الاسمنت لو مغطي الفيبيلا بالكامل مش مهم، حتى لو هي جوه الاسمنت. اهم حاجه الاوستيوتوميسايد بتاعها بروكسيمال وديستال ما يجيش عليه اسمنت، وده بيخليها تنتجريت وتهيل بعد كده.
في سؤال كمان من الدكتور ايميل عوض. About with destruction of unilateral cortex in aggressive giant cell tumor, how can you deal with the surrounding soft tissue؟
لا must be resected. يعني انت هنا لما تيجي تعمل الويندو بتاخد السوفت تيشو مع البريوستيوم انتجريتد في الويندو، يعني لازم تشيلهم كلهم كومبليت دروفنج وان ماس، عشان ولو حصل شويه يعني سيلز كونتامينيشن، عشان كده بنحط الهيدروجين بروكسايد لمده من 3 ل 5 دقائق. لازم يبقى بتغطي كل الكافيتي، لان ده بيعمل سيرما نيكروزس نص مللي زي ما قلنا، يمنع الكونتامينيشن عشان ما يحصلش ريكارنس من السوفت تيشو.
في سؤال كمان about من الدكتور وائل. في الديستال راديال جوينت سيل تيومر دكتور محمد، ال 3D printing technology can help in replacement of distal radius and reconstruction of the joint؟
يقصد الاندوبروستاتيك ريبليسمنت للديستال راديوس. هو في بيبرز اللي لسه متكلمه عليها، بس هي مشكلتها ان الفاسلز اللي ارتكيوليت الديستال راديوس هتعوضها بميتال زي كانك فيبلر جرافت. هي مشكلتك هتارتكيوليت مع ايه؟ السكافويد واليونيت از فيري سمول بون. ما هي نفس فكره التوتال انكل. ليه فيلد؟ في فيلير ريت عالي، لان التيرس بعد ما تعمل الكارتلج وتشيل الفيو مليمتر يبقى الفاضل من التيرس جزء صغير، البروسيس بيحصل له سانكينج في التيرس. هي نفس الفكره، الفيلير ريت بيبقى عالي جدا في الديستال راديال بروسيس.
في دكتور بيسال على الكونترا انديكيشن about the liquid nitrogen from your experience دكتور محمد other than joint preservation.
لا، ما انت لازم يبقى عندك كونتيند كافيتي. ما انا لو عندي التيومر واكله السوفت الكورتيسيز مور ذان 2 كورتيسيز از نوت بريزنت، ما ينفعش استخدم ليكويد نيتروجين، استخدم في الحالات الفينول. يعني لازم يبقى عندي شرط اساسي كونتيند كافيتي عشان اعمل بورنج، لان ده بيعمل سيلولار ديس وبنتريشن 1 سنتيمتر. فانت لو انت حطيته وحصل ليكج على النيورو فاسكولار باندل هيحصل سبازم في الفيسل، ده مصيبه. وبرده انا في حاله كان عندي حصل فيها برفوريشن في البروكسيمال هيومرس، كانت اجريسيف بون سيست، والعيان خرج عنده ميديان نيرف لان كان تاتشنج الجزء اللي حصل منه الليكج. بيتحسن بعد فتره، بس بتبقى مقرفه بقى ان عيان دخل تعمل له حاجه يطلع عنده ميديان نيرف، بيبقى يعني لغايه ما يتحسن شوف بقى الزن اللي بيحصل والقصه دي. فانت لازم تعمل سيلينج للبرفوريشن لو هو سمول، لكن لو مور ذان 2 كورتيسيز مش موجودين ما ينفعش استخدم ليكويد. الحاله دي بقى بستخدم الايه الفينول او الريسنت دلوقتي اللي هو الارجون، ده موجود في بعض الاماكن المختلفه.
في سؤال من الدكتور محمود حامد على الانسيدنس اوف جاينت سيل تيومر ان فلات اور سيسامويد بونز. هاو تو تريت كيرتاج اور اكسجن؟
لا، ما هي انهي سيسامويد بون؟ يعني سؤال يعني غريب بصراحه. يعني يحصل يعني الفكره فيها لا، اللارجست جان سيل تيومر في السيسامويد بون اللي ريبورتد هي بتاع الباتيلا، ده الوحيده. بس وما بتيجي في الباتيلا انت هل هي فيري اكستنسيف ولا يعني كونتيند؟ لو هي كونتيند بنعمل كريتاج انا عندي حالتين وعملت لهم كريتاج وفينول، لان الباتيلا ما هياش كبيره قوي بعد ما تفضيها، مجرد بتاخد بكده ايه لسعه فينول، يعني ما ينفع مش هتنفع تحط فيها لكن عندي حاله كانت فيري اكستنسيف وعامله بالوننج الباتيلا تقريبا بتاع 10 احجام السايز بتاع الباتيلا النورمال. الحالات دي بتعمل توتال باتيلكتومي وبتعمل ريكونستراكشن وريبير للاكستنسور ميكانيزم.
طب في دكتور سيف الدين حسام بيسأل على الكرايتيريا اوف نون سيرجيكال تريتمنت للجاينت سيل تيومر.
بص، هو زي ما قلنا القاعده العامه في الجاينت سيل تيومر هي السيرجري، وانس ان دايجنوز سيرجري، بس في اماكن زي البري استابلر اريا، زي في السكرم، زي في الفرتبرال بادي، هي فيري كومن في الفرتبرال بادي، ما بتجيش في البوستيريور ارش، احيانا بتبقى اكستنسيف. في رول دلوقتي على الدنسوماب اللي هو البروليا او الاكسجيفا، اللي بيعمل لها بريفرال شيل، بس لازم لو قريت البيبر اللي بتتكلم عليه هتلاقي اغلى من العمليه 15 مره. العيان بياخد البروليا ده حقنه اسبوعيا، والحقنه ب 2370 وهيمشي عليه لمده 22 اسبوع. ده الريكومنديشن اللي طالع من اولم وكذا جامعه في المانيا. لو حسبتها العيان هيصرف 100,000 جنيه عشان ياخد البروليا ده، وفي الاخر هيخليها كونتيند كافيتي بس ما بيحصلهاش كومبليت اوسيفيكيشن. وفي البيبر لسه قاريها من شهرين ثلاثه ان بعد ما يتوقف البروليا بيحصل ري اكتيفيشن للجان سيل تاني، يعني هو بيديك تمبرري ريزلت. فهو موصوف في الحالات اللي هي البري استابلر، اللي هي كل الاستابلم بتاعك بيسموه كومبليت بايش ما فيش فيه وولز، انك بتستخدمها لفتره يبقى يحصل سكند كورتيسيس تقدر تكحتها. برضه في السكرم نفس الكلام، انت عشان تشيلها في السكرم هتسكرفاي روتس، هي لو اديتك بريفرال شيل تقدر تعمل ايه كونتيند كافي.
شكرا لحضرتك دكتور محمد، كده تمام بالنسبه للاسئله.
دكتور محمد معلش احنا لازم نستغل وجود حضرتك برضه ونستفاد من خبره سيادتك. انا شفت الحالات اللي حضرتك عملتها، كنت حضرتك بتقول هو بعمل سي تي، يعني هل ده روتين ولا كان العين كومبليننج من حاجه؟
لا انا احيانا بعمل سي تي او ام ار اي لما تبقى الحاله يعني الريزلت كويسه، وبعملها فور ساينتفك ريزون، يعني بفهم العيان. احنا يعني انت بتقول له هنتابع ونعمل ام ار اي عشان نتاكد فيه، لا بس انا بعملها فور ساينتفك بصراحه. يعني انت عارف لما تبقى عامل حاجه كويسه وعايز تتابعها بمور انفستيجيشن بس، والعيان لو اكسبتنج ما بيبقاش مشكله، خصوصا لو انت شغال تبقى العيان بيبقى تبع شركه تامين او كفر ما يبقاش فيها مشكله. طبعا لو انا غلبان مش تقول له اعمل ام ار اي وانت بقيت كويس هيشتمك ومش هرجع لك. لو عيان في مستشفى محترمه وتطلب له اي ايفالويشن مش هيقول لا. بس وفي نفس الوقت بتنفعك، انت بقى معاك في الفايلنج بتاعك، ويبقى معاك دوكيومنت ان العيان بعد 3 سنين و5 سنين اكسلنت ريسبكت.
طيب الحاجه الثانيه حضرتك بتحب تعمل يعني امتى تعمل بروفيلاكتيك فيكسيشن للحالات؟ انا شايف حضرتك اللي حضرتك بتعمله دايما سيميشن
يعني انا
بتحب ولا حضرتك
لا انا في حالات، يعني عندي كام حاله اللي هو الديستال فيمر والبروكسيمال تيبيا، هو العيان جان سيل وجاي اوريدي باثولوجيكال فراكشر وديسبليزد. الحالات دي بستخدم بقى لوكد بليد، بس ما بستخدمش بقى فينول، بستخدم شيء قصدي ليكويد، مش بستخدم فينول. تعمل الكريتاج والايفاكويشن، بعد كده بتحط الفينول، بعد كده بحط بقى السبكوندرال جرافت والريدكشن، وبعد كده بحط ديستال باترس بليد، بتبقى غالبا لوكد بليد، يعني سواء ديستال فيمر او بروكسيمال تيبيا.
قصدي لو نازل وكونتيند حضرتك برضه ما يعني
حتى لو كونتيند انا بحط امبيدد سكرو. انا عامل مش عايز اقول لك عشرات ان لم يكن مئات الحالات بالامبيدد سكرو اللي هي اللونج، اللي هي المسامير ال6.5 ديت، ال 120 مللي او ال 110 مللي بتبقى سفشن، يعني عمر ما حصل منها فيليا. بس اهم حاجه زي ما قلنا تبقى معدي الكافيتي ب 2 3 سم، يدي لك برشيس كويس. حتى لو العيان جاله من ليكويد نانجين، في انستنس العيانين بيجي لهم اوستينيكروز وباثولوجيكال فراكشر بعد 3 4 اسابيع من الليكويد نانجين افكت، يعني زي ما قلنا بيعمل اوستينيكروز 1 سنتيمتر، فبيبقى كونتين، مجرد بتعمل له كبيره او تلبسه بريس 4 5 اسابيع بتلاقيه هيل، ما تحتاجش انك تعمل له ريسيرجي والكلام ده، حتى لو اتكسر بعد.
الحاله اللي حضرتك عرضتها بتاعت المالجنت جوينت سيل، هل حضرتك يعني في ريكومنديشن ان هو ياخد نيو ادجمنت؟
والله بص، مع زمايلنا بتوع الكيموثيرابي يعني قال لك there is no كيموثيرابي للجوينت سيل، بس هم بيريكومند لو انت في ريزيدوال او خايفين بيدوا بوست اوبرتيف راديشن. بس يعني انا عندي تقريبا 3 حالات او 4 مالجنان، طالما شلتهم كويس والريكونستراكت بتاعك كويس وستيبل ما بدهمش حاجه. يعني
لا بري اوبرتيف ولا بوست اوبرتيف؟
لا هي ملهاش، يعني الجاينت سيل تيومر ملهاش
حضرتك
اساسا، ملهاش.
تمام.
هو الحاجه الوحيده لو في لانج ميتس بيدوا مونوكلونال انتي بودي، يعني ده اللي بيتكلموا عليه. بس لو في لانج ميتس او بيدوا البروليا لو في لانج ميتس بحيث يحصل لها اوسيفيكيشن ويتسيبها زي ما هي.
اتفضل يا دكتور محمد.
شكرا جزيلا استاذنا الفاضل استاذ الدكتور محمد بيه عبد الرحمن for this very interesting talk. Thank you so much sir.
العفو.